Hey everyone, Dr. David Clark here. Today I'm going to be walking you through another real patient case study from my office. Today we're talking about a 63-year-old man with Meniere's disease, and so he has associated vertigo, tinnitus, and headaches. Let's talk a little bit about his chief complaints. So he's having multiple episodes per week of vertigo, right? This rotational feeling, the room is spinning, it's very disorienting, make you sick to your stomach, sometimes you even vomit. He has room spinning, right? He has dizziness. Now, dizziness isn't necessarily rotation. It's that feeling of being unstable or having some disequilibrium. And he's having nausea. And he's having multiple episodes of that per week, not like once a month or one every few months. In the time preceding before I saw him, he was having these multiple times per week, which if you can imagine, that's a terrible quality of life. Now, constantly, he is having fullness in his right ear, and we would expect that with Meniere's disease. He's having tinnitus or ringing in the ears. He's also having occasional vomiting because the episodes and the attacks are so severe. And he had to stop work as a mail carrier because of these attacks. He was having so many attacks and they were so unpredictable that he was having to stop his mail route many times and have someone come and pick him up and have someone else finish the route. So he's been out of work for a while because he simply can't do his job. He can't drive. It's too dangerous. So that's what we're working with in this case study. And so if you've got Meniere's disease that's unstable, that's still getting worse, that's waxing and waning, I think you're going to find this case very, very helpful. So let's get a little bit further into it. Okay, so if we look at his health history, right, we're always looking to see what clues can we get from someone's history. I always have people fill out a complete, what I call an intake, right, a very detailed narrative written history of what their whole health history has been, not just, their current complaint, but what has their whole health history been? Because oftentimes there's clues in there, but you have to ask for it. And I have people fill that out before they even come into the office, because there's no way you can just fill that out waiting in the waiting room. And you need to take some time. So that being said, this guy was fairly healthy according to his own report. He had COVID 2 different times, once in October 2021 and one in July 2022. What do we know about COVID? Well, COVID is extremely inflammatory, loves to stimulate different types of autoimmune problems, whether you have a family history of them or not. And it can have a real strong hangover effect on your immune system for 6 to 8 months. So I'm really interested in what's going on with this guy's immune system, as I am with every Meniere's patient, because if you guys have followed my channel very often or very long, you'll know that a large number of people that I see that have Meniere's disease that isn't stable, it's their immune system in some form that's going on. That's the problem. So let's see what we got here. So before 2021, he really was, he says he was healthy and he really had no complaints. And then in October 2023, he had the onset of headaches, which he'd never had before, some dizziness, which is not really spinning, but kind of that disequilibrium, just kind of unsettled, ungrounded feeling. And he was having some ear symptoms, some fullness, right? Then a month later, he had a severe, sudden, terrible episode of vertigo with violent vomiting. Now, when that happens, we get scared that someone might be having a stroke or something like that. So he went to the ER, which is what he should have done. And they had a workup, which included an MRI, an MRA, looking at his blood vessels. All that was negative. So since then, he has had regular vertigo attacks. So since that time in November, that's when all heck broke loose, and he's had consistent and regular vertigo attacks since then, which is just a terrible thing to imagine. And he's seen 7 different doctors before me, and he's still getting worse, and he was getting no definitive diagnosis. So let's dig into that for a minute, because I think it's interesting, it's kind of a teaching lesson to see what he went through. So first doctor he went to early on said, hey, you have a little liquid behind your eardrum, maybe you have a slight ear infection, and gave him some prednisone. Now, steroids is something that a lot of people with Meniere's are given because Meniere's is an inflammatory problem, and steroids tend to, in most people, make them temporarily better. Temporarily, as we'll see, because usually once the steroids wear off, in 60 to 90 days, sometimes the symptoms come back. So doctor number 2, the ER doctors had suggested that he had BPPV, which is benign paroxysmal positional vertigo. And I'm not sure what about his presentation would have made them think that, because there's a test they could have done in the ER, basically, which is called a Dix-Hallpike maneuver, and find out, does he have BPPV or not. So they referred him to an ENT, which is fine. Send him there and they'll do the workup. So the ENT, which is doctor number 3, says, hey, you have inflammation behind your eardrum. I'm going to give you prednisone. Again, prednisone again. The hearing test that person did showed that he had hearing loss. Now, hearing loss plus rotational episodic vertigo, plus ear fullness, plus tinnitus, that really sounds like Meniere's disease for all intents and purposes. But sometimes doctors don't give I'll put it this way. Sometimes well-meaning doctors won't do treatment on someone unless they can have that person check all the boxes. And if you don't check all the boxes, they won't do any treatment because they kind of feel handcuffed. And I think that's a problem with how some doctors work. But the doctor didn't think it was Meniere somehow. With the hearing loss and the vertigo and all that, the doctor didn't think it was Meniere. So, I mean, he was wrong, but I guess that's, it's a decent guess to say it wasn't Meniere's disease. Anyway, so what did that doctor say? The doctor did say, though, even though it wasn't Meniere's, that he should follow a low sodium diet, 1,500 milligrams a day or less. That's a great recommendation. Great recommendation. And also recommended him for vestibular therapy. Again, this is kind of maybe a teaching moment here. Some ENTs that mean well, when they can't really figure out what's going on with someone, they send them to vestibular rehab and hope that the physical therapist can figure out what it is. So, but he didn't do that. Scratch that. And so he did the vestibular therapy, and he did okay for about 3 weeks. 3 weeks. Now, Dr. Ford that he saw, which is PCP, said, hey, you have inflammation in your ear, and recommended that he see a neurologist. Okay. So he's seen emergency room doctors, his PCP, an ENT, some vestibular rehab for a couple of weeks. Now he's getting told again that you should see a neurologist. Okay, so doctor number 5 is actually a nurse practitioner that he gets in to see, and they prescribe an antihistamine for his headaches. Kind of helps a little bit, and that brings up a question whether the headaches is something you see in Meniere's all the time or no. And you really don't see it all the time, but in this guy, he definitely has headaches as part of his presentation. Doctor number 6, who is a chiropractic neurologist, I am a chiropractic neurologist. I do a lot more than that, but this chiropractic neurologist adjusted his neck. Symptoms got worse, so he discontinued. It wasn't like he was hurting his neck. It's just I don't think that was probably the mechanism behind this patient's Meniere symptoms. So, doctor number 7, another nurse practitioner, says, hey, stop using Q-tips. Right? That's what the problem is. You're using Q-tips. I mean, come on. Said you got liquid in your ears, gives them a diuretic to take for 30 days. Well, diuretics are also something people with Meniere's often get given because there is swelling in the inner ear and there's no place for it to go. And the idea with the diuretic is you decrease the fluid accumulation, because one of the other names for Meniere's is something they call it endolymphatic hydrops. And endolymph is a fluid in your inner ear, and hydrops means you have excess fluid. And so the idea is give you diuretics, it will pull the fluid away, and then maybe your symptoms will stabilize. And that does work for some people. Now, at the follow-up visit for this person that told him to stop using Q-tips and gave him the diuretic, he said, you might have possible Meniere's disease. And, this is I guess my reason for showing you all of this long road this guy had is because he was working with people, doctors, and well-meaning people in a system that kind of says, we don't know what to do if we can't give it a strong name. If we can't give it a full label, I don't know what to do. And physiologically, there's a lot you could have done for this guy early on. It's just that the people he was seeing, that's just not what they did, because they needed him to check all the boxes before they would do anything really super proactive. Now, they did give him prednisone, that's fine. They did give him the diuretic, that's fine. But they're kind of working in a small toolbox. They also said, hey, you might have migraines too. Maybe that's why you have all these headaches. So I can tell you with that migraine possibility, what they're veering off into is saying maybe what you have is vestibular migraines. And yeah, I mean, maybe, but with the hearing loss and the tinnitus and the ear fullness, that's not vestibular migraine. People do have vestibular migraines. Just had a patient recently, had a terrible vestibular migraine that really put her down for 3 or 4 days, but this guy's having these attacks all the time. So for me, I don't think it's probably vestibular migraine. All right, so when he sees me, he's now having many episodes per week. He had some at work while he was mail carrier. He had to stop working. He had to have his route interrupted. So here's the family history. The only thing in his family history is he had a mom with migraines. So I can tell you, if the other doctors he saw knew that, part of what is in their mind is this guy might have vestibular migraines. That might be what this is. But as I said a minute ago, his whole constellation of symptoms, that doesn't really seem like vestibular migraines to me. So what is he currently taking when he sees me? Well, he's taking a multivitamin, magnesium, and then he's taking something for migraines. which is riboflavin and a butterbur ginger combination, which is something that there is an evidence base for, but it's not really helping him because that's not what he has. He doesn't have migraines. Occasionally he's using meclizine, which is basically just a vestibular sedative to help prevent the nausea and the vomiting. It's not curative in any way. Now for the daily headache and the head pressure, he's been taking Advil in the morning basically every day. And as you know, that's not going to be something that's good for his GI tract in the long term. All right, so diet, right? Remember that person had told him a long time ago, you should be following a low sodium diet. Well, you know, this patient says his diet is not 100% gluten-free and definitely not dairy-free. And if you're trying to be gluten-free, you might as well just be 100%. You don't be 98% or 95% because it's really not going to tell you anything. He says he has reduced his intake of both gluten and dairy, but he's not avoiding them completely. He also really reduced his caffeine intake, which was pretty high, which is a good idea. I mean, I've made some videos on different triggers for Meniere's disease attacks, and caffeine is one of the things that can do that. Also gluten and dairy. Now for the sodium, this is interesting. He'd been using an estimate from this thing called his MyFitness app, and it showed that he had an intake of around 2,500 milligrams per day. I told him from day one, I said, you need to immediately get that down below 1,500. Why? Well, if you look at my other video on sodium, sodium in itself above a certain threshold is inflammatory. And since I already know that most people that see me with Meniere's have some sort of immune system inflammatory problem, we better get below a threshold, and 1,500 is usually pretty safe for most people. Plus, sodium also brings with it water. And if we're having excess fluid accumulation in the inner ear, we don't want to be drinking a lot of sodium because it can bring fluid with it and, of course, make it worse. So that's the first thing I told him right off the bat. Now, I made him say, hey, you know, slash that in half and let's get it around 1,500, okay? All right, so what do we do now? So it sounds like Meniere's disease to me, right? It walks like a duck, talks like a duck. He's got hearing loss, tinnitus, all that sounds like Meniere's to me. It's in the right ear for sure. He's had basically no lab testing so far because remember, all these people he's seeing really aren't thinking about this as an immune system problem that can be helped. Meniere's is often treated like a, you know, it's just something you're going to have to live with. Now don't get me wrong, there are people, there are ENTs, there are neurotologists that don't look at it like that, but the vast majority of people that this guy could have possibly seen just aren't going to look at it like that. And they're certainly not going to look at it the way that I'm looking at it. So we're going to do some lab testing. So 4 priorities. What I always tell people is one way to not get lost in all this, you know, functional medicine, biochemical stuff is to think about the 4 priorities. And the 4 priorities are basically the 4 questions that I'm trying to answer for every patient. And here they are. Number 4, what's going on with his GI and liver system? Doesn't have any overt symptoms of that, but we'll do a little blood testing and see if it shows anything. Priorities 2 and 3 are all about energy production. They're all about glucose handling, hypothalamic pituitary adrenal function, anemias, all the things that go into making ATP like B12 and folate and ferritin, folate not really, B12 and ferritin, B vitamins, mitochondrial health. Now, this guy hasn't really given me anything in his history about blood sugar problems or glucose handling or energy production problems, but we're still going to check for it. And then priority number 1 is what is the patient's immunophenotype. Now, what does that mean? Years ago, I used to just say, does the person have an autoimmune problem? I've made that a little more accurate now, and I'm starting to use the terminology, what is the person's immunophenotype? That just means what is this person's immune system doing? What does it look like? And autoimmune is one of those immunophenotypes, but it doesn't have to be that. It could be an inflammatory phenotype. It could be an autoinflammatory phenotype. It could even be an immune system deficient inflammatory phenotype. And I've had some cases with that. So we're going to do some testing to try to get to the bottom of this. So what's this immunophenotype? All right, so here's at all the blood work we did, these are the main findings we found. So we had a homocysteine of 13.2. So what is that? Essentially, homocysteine is a substance that we've all got, and it's not a big deal as long as you are recycling it. And we primarily recycle it with B12 and folic acid. If you don't recycle it, its levels start to pile up, and it very strongly promotes oxidative stress, promotes inflammation. Very bad for the cardiovascular system, bad for the cerebrovascular system, makes your brain age faster. We don't like it. Now, you'll notice 13 is not outside that lab's range, but I'm telling you, anything above about an 8 or 9 is too high. So I immediately know that this guy is going to have a higher level of oxidative stress and a higher level of inflammation because of that. So his vitamin D, 37.5, that's not really good enough for my standards either. Why? Because Vitamin D is immune system regulatory. It's anti-inflammatory. And 37 is not deficient, but I'm telling you it's not a great level. I would like to see it in like the 70s or 80s. Now his folic acid and his B12, I mentioned that a second ago. I'm just going to kind of show this on the screen for you guys. Methylmalonic acid is the best test for vitamin B12. And these levels here are inversely proportional to B12. So the higher that number is there of methylmalonic acid, the lower the B12 is. And his B12 is fine right now. But his folic acid, you'll see, is a 10.8. That's not good. Again, you'll see that it's not deficient, right? It's not under 3, but 10 is too low. 10 is definitely too low. Folic acid is necessary for recycling homocysteine. It's necessary for making DNA and RNA work. It's necessary for neurotransmitters. So we're going to have to fix this. I can't tell you for sure if the homocysteine has anything to do with his ear symptoms and his Meniere's because I don't know that, but it's still going to have to be fixed because it certainly could not be helping, right? So homocysteine's too high, vitamin D's too low, folic acid is too low. Now, I haven't gotten into the question of why his folic acid is too low because it's kind of hard to become low in folic acid unless you're a vegan or vegetarian, you don't supplement. But you can also get low folic acid from malabsorption. You can get lower folic acid levels because of an MTHFR genotype. We're not going to get into that in this case, but we do need to figure out why his is like that. All right, so homocysteine too high, folic acid too low, vitamin D too low. That's what we got just from the regular blood work. And the thing is, I could not have presumed or like guessed. I just have to do these tests and find out if they're there or not. So we're going to have to fix that. Now, let's look at his immune system. So this is a multiple tissue antibody test. So remember, I'm looking for his immunophenotype. And one of the immunophenotypes that you can see in Meniere's is an autoimmune problem. An autoimmune means that your immune system is attacking you. What it means is you are making antibodies for various tissues. So let me just explain this. An antibody is like a Post-it note that your immune system makes to stick onto something. Now, we have a lot of antibodies, a lot of Post-it notes floating around for a lot of different things, and that's normal. But if you make a big stack of Post-it notes to stick onto one of these tissues, that's not normal. That's probably an autoimmune condition. Now, antibodies can basically show you one of 3 scenarios. They can show you a preclinical scenario, subclinical scenario, or overt disease. Preclinical means that you've got the antibodies, but you don't really have any symptoms or other associated test findings that we would associate with that tissue antibody, right? So it's preclinical. Doesn't mean you're okay. It means your immune system is definitely targeting that thing, and antibodies can show up 5, 6, 7 years before you finally get diagnosed with the condition or the disease associated with that antibody. Okay, antibodies can also show you something that is subclinical. That means you got the antibodies, you've got some of the symptoms and findings we would associate with that, but you don't check all the boxes, right? That's called subclinical. Now, overt or just clinical disease or clinical condition is when you've got the antibodies and you check all the boxes for a named condition associated with that tissue antibody, right? So that's what these antibodies can show us. Now, what does this gentleman have? Well, you can see that in the out of range column, what has he got? He has got ASCA and ANCA antibodies. Those are basically antibodies that show up in a couple different conditions. They show up in inflammatory bowel disease, irritable bowel syndrome, Crohn's disease, ulcerative colitis. I'm not going to dig into those too much except to say that he doesn't have any GI symptoms, right? So if anything, these are probably preclinical. But as I'm going to show you, there are foods that cross-react with this. And we'll talk about cross-reaction in just a second. So ASCA and ANCA, you know, ASCA means anti-Saccharomyces cerevisiae antibodies, which is literally baker's yeast and brewer's yeast. And ANCA is anti-neutrophil cytoplasmic antibodies. These can also show up in certain what we call vasculitides or vasculitis, although he really doesn't have any symptoms of that. So what else showed up? Well, we had both osteocyte antibodies and cytochrome P450. All right. So osteocytes are bone cells, and people that get these antibodies, they show up in osteoarthritic conditions, arthritis, but it's autoimmune, okay? It's not rheumatoid arthritis, it's osteoarthritis, right? You know, the joints get big and they get knobbly and all that, but the cause is autoimmune because your immune system is killing off these bone cells. The other people that get these antibodies are people who have osteoporosis and osteopenia. So His are out of range. We don't know if he has any osteoporosis or osteopenia because we haven't done any bone density testing, but he doesn't have any arthritic symptoms that we know of, so maybe these are also preclinical. But what about cytochrome P450? Well, that's a liver cell, right? That's inside a liver cell. He had no liver enzymes elevated. He has no liver symptoms, but he's got these antibodies. And people that get these antibodies can, kind of two things that are kind of exotic. You can see them in autoimmune hepatitis. You can also see them, some people with mold exposure of a certain kind can get these. But, as I'm going to show you in a second, there are food cross-reactors associated with this. And then he also had something called synapsin, right? Well, synapsin, people that have that, they show up in demyelinating conditions, which is like MS and other things like that. They can show up in altered neurotransmitter release. There's not a lot of literature on synapsin, but we do know that it does show up in certain conditions. Now, he doesn't have anything that lets me think he has a demyelinating problem. But again, this might be preclinical, but maybe also there's a food involved with this because there are known food cross-reactors. And the last thing he did definitely show up with, which was a surprise for him, was thyroid peroxidase antibodies. Now, elevated thyroid peroxidase antibodies means you now have this thing called Hashimoto's. Now, his thyroid panel, his TSH, T4, T3, all that was normal. So we would say that he has euthyroid Hashimoto's, or we would say it's preclinical, right? Because he doesn't have hypothyroidism. His thyroid hormone levels are fine, but he's got these thyroid antibodies. So all of these, are they all preclinical? Yeah, maybe, but let me show you something. The other thing that this test can show us is what foods he probably ought to be avoiding based on known cross-reactors. So what is cross-reaction? Cross-reaction is when the antibodies, the post-it notes for one thing, can stick to another thing, even though they're not the same thing. The immune system really can't tell the difference. So what that means is the following. So the known food cross-reactors for ASCA and ANCA are milk and baker's yeast, meaning the immune system can't tell the difference between those and ASCA and ANCA, right? It can't tell the difference. And so if you eat these things, you have a high chance of making those antibody levels higher. And if it was preclinical, now it can go to subclinical or overt a lot faster. What about osteocyte and cytochrome P450? Well, we'll stop there. What about thyroid peroxidase? Wheat, see milk, see the common thread? Corn, and there's a bunch of others I won't go into. What about osteocyte and cytochrome P450? Well, wheat, milk, and pork. Okay? What about synapsin? Wheat. So you guys see the common thread, right? Remember he said he wasn't 100% gluten-free and he really wasn't 100% dairy-free? Well, look at all these foods right here that are probably an issue for him. Now look, I didn't do IgG food sensitivity testing because that, my friends, is a waste of time. We're not even going to talk about that for a variety of reasons. One day I'll put a big video up on YouTube and I'll get flamed for it. But the point is that testing does not help us. It does not tell you what you think it does. This, however, what we're saying is, hey, you've got elevated tissue antibodies. We already know from the research what things cross-react with this. Let's don't eat those things because there's a high chance of making the autoimmune problem worse. Okay? Now, that's what his multiple tissue antibody testing showed me. But we also need to, so hit the cross-reactors, wheat, milk, baker's yeast. Okay, cool. What did his lymphocyte MAP show us? So this is a test that is lymphocyte immunophenotyping. This is looking under the hood of his immune system, not looking at antibodies, and saying, okay, what are the T cells and B cells and natural killer cells? What are all those doing? Okay, so his doesn't look that crazy, right? So I'm not going to spend a lot of time going through, but let me just show you. So if you look at the ratio of his T cells and B cells, you know, it's pretty normal. If you look at the ratio of his CD4 and CD8 cells, pretty normal. If you look at his T helper 2, T helper 1 cells, yeah, his T helper 2 are high, but the ratio of Th1 to Th2 is pretty good. So what are we doing here? Well, look down here. See these natural killer cells? They're definitely elevated, okay? So what do they do? What does this mean? Well, when natural killer cells are elevated, they're part of your innate immune system. And their levels can increase if they're trying to kill a virus or kill virus-infected cells. And you can definitely see natural killer cells elevated for months and months and months after you've had COVID. Now, it would be weird for his to still be elevated so long after COVID, but there they are. So what can we make of this? Well, here's what I'll tell you. You'll see that his lymphocytes that are total are, a little on the lowish end. It'd be better if they were 2,500. And we talked about the Th2, and we talked about the natural killer cells. But in this guy's case, yeah, he's got high Th2. Is that indicating some kind of inflammatory problem? Because really, you know, there's a Th1, Th2 teeter-totter, there's a T and B cell teeter-totter, and I went through those. His teeter-totters aren't that unbalanced, it appears, right? So is his high T helper 2 cells because there is some inflammation? Is his high natural killer cells there because there's something called neuroautoimmunity? That's something that can cause natural killer cells to be elevated. It means you're attacking nervous system structures. That's a possibility. Or is it just post-infectious? I mean, I got to tell you, I look at this and go, well, this panel's not really helping me that much. So what am I going to do? Because, you know, I know that there's a lot of autoimmunity going on with those antibodies. I know I've got oxidative stress. I know that Meniere's. So based on my clinical experience, here's what I'm going to do with this guy. We're going to fix the folic acid and the homocysteine. We're going to replenish his folic acid and get the homocysteine level down. We're also going to put him on a short-term, what I call an anti-inflammatory repair diet. I'm not going to tell you exactly what that is because I don't need you guys trying to adopt this yourself, because you need to work with someone that understands all this, okay? So don't get mad at me for not giving you the exact treatment. But part of what that diet is we're going to avoid those cross-reactors, avoid the wheat, milk, the baker's yeast, and the corn, plus some other things that I know have a good chance of being inflammatory. Low sodium diet, right? Got to make sure, I'm telling him he's going to have to keep his sodium under 1500. Now, we're also going to put him on an anti-inflammatory, immune regulatory supplement protocol. Why? Because I think that's probably an issue with him. Just from my clinical experience, odds are that his immune system is a problem. And I know that there's autoimmunity, even though his lymphocyte MAP wasn't like super, you know, super helpful in that regard. I still think it's probably our best bet. So let's see what happens. So after 2 weeks of that treatment plan, I get an email, and here's what it says. It says, "Greetings, Dr. Clark. Before my question, I just wanted to let you know how well," I'm not going to put his name in there, "how well hubby is doing. For the last 2 weeks since doing this repair diet and taking the supplements, he has not had any vertigo episodes, but even more importantly, no ear pressure or headaches, which he was having daily." So 2 weeks into the protocol, no vertigo episodes after having them daily, no headaches after having that daily, no ear pressure after having that daily. So something we're doing is on the right track, right? We're moving the needle. And that's what I always tell people is I like to do my treatment plans in 30-day chunks, even with Meniere's, because that's usually enough time to find out if you're on the right path. Like, it's not going to take 6 or 9 months to figure out if you're doing the right thing. It may take 6 months to figure out if you're stable, but already we're seeing a really, really good response. And this is not that out of the ordinary, to be honest with you guys. Not everybody has this kind of response, but I would say I'm just not surprised that he had this good of a response. So that's after 2 weeks. Now, after 3 weeks, 3 days, you know, just another 10, 12 days, I get another email that says, "Hey, a hubby's been on that repair diet without deviation, and he's taken the supplements, and he's had no symptoms at all since June 30th. They're extremely encouraged." And so they're like, "Hey, we're going to be running out of stuff. Should we be taking them? Should we continue taking them?" Yeah, absolutely. Definitely need to keep doing the protocol, right? Now, we're not even done our first follow-up really, right? This is just email communications. And they're just like, they're both elated and shocked how much better he's doing, but they're also a little scared, you know, that he might suddenly not be doing so well. But yeah, we're definitely not stopping what we're doing yet. All right, so after 5 weeks, 8 days of the treatment plan, here's another email I get. So they'd email me and I'd said, "Hey, you know, you guys can open up his diet a little bit. We can try to add back some tomatoes." And he was needing some protein, so I gave the go-ahead to try this protein shake that was made from egg protein, and he had no problem with it. Now that's very important because what I do with this repair diet, which is very restrictive, at some point we reintroduce foods, and reintroducing them is a test, and so far he's passing the test, okay? I'm not going to get into that too deep except to say that this is the longest he's gone without symptoms since last October when everything started to fall apart. So this is really good stuff. Needless to say, he's thrilled. I asked him what he'd like to try next, and he said, whatever Dr. Clark suggests, right? So we look forward to finding out what his next trial food will be. Thank you is a tiny word for how big our appreciation is for how well he is feeling. I mean, this is the kind of stuff that makes getting up in the morning easy, right? It's the kind of stuff that makes coming to work and working with people easy, because you know that oftentimes there's a big chance for them to get better. I mean, you don't know until you treat them, but I was very optimistic for him, and I'm really glad that after just 5 weeks and 8 days, he's doing essentially 100% better and maintaining it. All right, so what now? Well, I said, hey, let's introduce a few food items in addition to the things I just showed you guys. Again, that's a test, and we'll talk more about the test some other day. But he's going to continue that low sodium diet, that supplement protocol, and we're going to retest his folic acid, homocysteine, and vitamin D and say, okay, what about the levels of these? Is he absorbing this stuff? You know, are we giving too much? So let's see what we got. All right, so 11 weeks into treatment, there's his original blood chemistry numbers, right? So this is what we got now, 11 weeks into it. So the homocysteine is now a 9.2, and that's fine. I'll take that. If it never goes lower than 9, I'm okay with that. But we went from a 13 to a 9, and his folate went from a 10 to greater than 24, so I know he's absorbing it. Now, is greater than 24 dangerous? No, it's not dangerous at all. But now I know that at least that oxidative stress that was coming from the homocysteine has to be more under control, right? That's a good thing. What about the vitamin D? Well, the vitamin D is now 127. So we went up like 70-something points. Now, is that dangerous? No, it's not dangerous. It's a little higher than I want. So I am going to have him stop taking vitamin D for a little while and then recheck it, kind of establish a new baseline. But that's not a toxic level. I'm not worried about that. But I do know that he can absorb the vitamin D. And I do know that it was probably having some anti-inflammatory effect. So what are we going to do? Well, after 11 weeks of the treatment plan, this is the email report they send me. So we're about 11 weeks in, almost 4 months, right? No, 3 months, yeah. So just look here at the bottom. It has now been over 11 weeks with no symptoms, and we are elated and very thankful. After a while, probably after a while, he was going without symptoms for a couple of weeks. He went from working indoors in the mornings, sorting mail, to delivering on his route. So he was able to go back to his full job. He's continued regular exercise. It's at home and sometimes in the gym. He's been able to ride his bike again without fear of falling over. And it's a 10-mile plus ride. I mean, that's pretty good. This is a guy who was essentially homebound and debilitated because of his daily episodes. He's continued on the low sodium numbers you requested. He's tried black beans, etc., etc. He's continuing supplements except for the vitamin D. So we're 3 months into this, and he has essentially been symptom-free for 3 months. That's fantastic. Now, I am going to give you guys a couple of caveats in just a second, but this is really, really good. So what do we do now? Well, we're going to continue to reintroduce a few food items. He'd only done about 4 or 5 so far, and no problems. So what are we going to continue at this point? Well, we're going to continue that low sodium diet. We're going to continue that protocol. We're going to know vitamin D for a few weeks, and then we're going to retest and kind of establish a new baseline. All right, cool. So he's doing great so far, but there is a caveat to this. So I don't want you guys to think that this is some kind of miracle treatment or that it works this fast for everybody. But more often than not, most of the Meniere's patients I see do really well with whatever we get them finally started on. Not necessarily the same treatment plan as this guy. Most Meniere's patients I see do have something going on with their immune system, but what that is very varied. The phenotype of that is very varied. In this gentleman, we saw lots of tissue autoimmunity, probably problems with the gluten and dairy, but we didn't really see a lot of craziness on his lymphocyte map. And so I just said, hey, this walks like a duck, talks like a duck. Here's what I've done with Meniere's patients in the past. Let's see if it works for this guy, because if it does, then we're going to know that the treatment is the test. So he's doing really great so far. But Meniere's disease can fluctuate, meaning sometimes people can go 6 months, 8 months without an episode, and then they'll get a flare-up. But here's the thing with this guy's case. He had a very rapid response after months of getting worse, right? October, November, December, worse, 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 worse. Taking steroids, they help a little bit, and then he gets back to being worse. So given his rapid response to a really worsening condition, I think the odds are in his favor that he's actually legitimately doing well and not just in a, just a random trough, right? Like where things have calmed down. He's back to full-time work. He's back to exercising in the gym. He's riding his bike, feeling life is a little more full and complete. And if he's stable over the next couple of months, if he continues to be stable, and if he wants to do this, what am I going to do? Well, the goal is not for him to take that supplement protocol for the rest of his life. Now, the diet stuff he may have to do, especially the low sodium diet, for here on out, because he's got all this tissue autoimmunity. But if he's fairly stable, like, symptom-free over the next few months, and if he wants to do this, I'm going to suggest we start to titrate or pull down some of his supplemental protocol to find out what do you still need. Now, a lot of people, Meniere's, that are doing well with this program and this protocol, their own protocol. They don't want to change anything. And that's okay, as long as they're up for it. But ultimately, kind of, scientifically, academically, I would like to find out, what does he really still need? And we're going to try to find that out. So why did I show you guys this case? I showed you guys this case because here's a guy that was doing terrible, and now he's doing great in a very short amount of time. Now, that's not everybody, okay? I'm not promising anybody anything. But you want to work with someone as your doctor that understands this stuff that we went through today, right? Now, the other doctors he saw, the ENTs, they're doing what they're trained to do, but it frankly just isn't enough in most cases. If you still have Meniere's disease, or you got someone that you love that has Meniere's disease and the symptoms are waxing, waning, and they're not stable, you need to find someone that can do what we talked about here today, right? Investigate those 4 priorities, know what to test, know how to interpret the test, know how to develop a treatment plan, know how to find out if the treatment plan's working. Because the truth is, you don't have to suffer, you don't have to live in fear, and that is one thing that almost all Meniere's patients suffer, is they live in fear of an attack because they don't know when it's coming. But there is a lot you can do. So I hope you guys found this case helpful. There's more to come. I'll update you with more things as we finish with him. So I'll keep you posted as he moves along and let you know, hey, how long was he stable? And I'll see you next time. Have a good one.